does highlight something very important, which is prevention. Infections like meningitis are often prevented through vaccination, whereas today we're focusing on screening, which helps detect other conditions early, often before symptoms develop. So both are part of the same bigger picture, protecting our health through prevention and early action. So even though today's topic is about health screening, we will have a brief chat about meningitis at the end. Dr. Veline will share some slides. So, what is health screening? Many conditions develop silently without obvious symptoms, and by the time that they are detected, they may already be advanced. Screening gives us the opportunity to detect early, prevent complications, and make informed decisions about our health. I'm really pleased to be joined today by two excellent speakers, Dr. Veline L'Esperance and Ms. Pamela Njawe. So Dr. Veline will be starting the first talk. She's a GP, senior clinical lecturer, and co-lead of Black Health Legacy at Queen Mary University of London. She is also a senior clinical advisor to the NHS Race and Health Observatory on Genomics and Precision Medicine. Her research focuses on health economics, genomics, and health inequalities, with a particular focus on improving diabetes diagnosis and outcomes for Black communities in the UK. Dr. Veline, over to you.
Thank you very much for a wonderful introduction, and thank you very much to the CON team for inviting me to do this talk. So if just give me one moment, I will share my screen and then we can get going. Great, so let's get into it. I'm first going to talk about diabetic eye screening. And we do diabetic eye screening because we're looking for diabetic retinopathy. So what is that? It's essentially damage to the blood vessels in the retina that's behind at the back of the eyes. And that's due to chronically high blood sugar levels. And it's a common complication in type 1 and also type 2 diabetes. And it happens because high levels of glucose then weaken and damage the blood vessels at the back of the eye, causing them to leak and swell, and then causing abnormal new blood vessels to grow. Left untreated, it can lead to bleeding and detachment, and then ultimately irreversible sight loss. There are various different stages, and then symptoms in the early stages, there aren't that many, but in the latter stages, you have things like blurred vision, floaters, sudden vision loss. So that's why early detection is extremely critical. And it's critical because 1 in 3 people with diabetes develop some form of retinopathy, so some form of diabetic eye disease. And importantly here, it's the leading cause of preventable blindness in working age adults in England. And over 4 million people in England living with diabetes are at risk. So that's why screening is very important, which you're invited to every year, and my colleague will discuss about that a bit later. So what about in the Black community? Well, 52% of people of African and Black Caribbean backgrounds with type 2 diabetes have some form of diabetic eye disease. And that's comparable to only 38% of people of white European ancestry, okay? Also very important is that clinically significant macular edema. So what does that mean? Sort of that's the hemorrhage or the water, the edema you're getting in the eye. It's 3 times more common in Black people compared to white Europeans, okay? And also more likely to develop sight-threatening diabetic retinopathy, even after adjusting for things like glucose, cholesterol, and deprivation. So again, that tells us that we're at higher risk of diabetic eye disease, and the reasons why we need to think about engaging in screening when that letter comes through. Okay. Now moving on to breast cancer. Very common, we have 57,000 new cases a year. But what is breast cancer? It occurs when cells in the breast tissue grow and divide uncontrollably, okay? And it's most common in women, but men can also develop breast cancer as well. Although it's rare, it is still possible. So if there are any lumps that you feel, men out there, you do need to go and have that checked. So moving on, the signs and symptoms. So you can get a lump or thickening in the breast or in the armpit. Any changes to breast size or shape, any nipple discharge or changes in the nipple that just doesn't look right. And any sort of dimpling or in-pouching or puckering up of the skin as well. Sometimes you can develop a rash. That rash can be anywhere from red, pink to actually darker blue in Black women as well. So when we think about risk factors, age, so increases significantly over the age of 50. However, all women, of any age, you should be doing breast examinations, self-breast examinations on a monthly basis. So you choose a time of the month that you will remember. That can be the first day of your period, for example, or the last day of your period. And you consistently check your breasts, and that allows you to know what normal feels like for you, so that when you go to the GP or you go to the doctor and you say, I've felt something that's different for me, they understand that. So it's really important to get to know your breast and what your breast tissue feels like. But really important, when we think about risk factors, dense breasts, so breasts that are quite lumpy anyway, obesity, alcohol consumption, and not having children is also a risk factor. But we do know that survival rates are strongly associated with stage. Okay, so early stage detection, essentially within 5 years, exceeds 98%. So that's really important. If you feel any sort of lump or any changes, anything that you're entirely worried about, do go and see your GP. Really, really important. So breast cancer in Black communities. So there's a paradox here. So Black African women have a lower overall breast cancer incidence, yes, but face more aggressive disease, later diagnosis, and worse outcomes, okay? So as Black women, we're 2 times more likely to present with late stage, high grade, so that means advanced, breast cancer compared to white women. So again, this is why we need to get to know our breast tissue, and then know what's different for you. And you can't know that unless you don't engage in monthly breast examinations. That's very important, okay? And again, some work out of East London found that Black women presented with breast cancer earlier as well, compared to white women. So 46 compared to 67. So that's a 21-year age gap. So that's really important, why we need to engage in these examinations and engage in the screening process as well, as Pam will discuss. We also then need to think about various types, the genetic changes that you can have with breast cancer. So with triple negative breast cancer, so that's where the different genes sort of predisposes you to that. It's harder to treat, and there's no sort of targeted hormonal therapy. Okay. So although Black women have a lower lifetime incidence of breast cancer, there's still a higher risk of breast cancer in Black women compared to white, in those 45 and under. Really important. So that's why monthly examinations, because we don't necessarily fall into that screening category until we're 50 and over, as Pam will go into. So moving on to colorectal cancer. So that develops in the colon. So that's the large intestine or the rectum. Yeah. And it typically begins with a non-cancerous polyp. So that means that it it starts with a sort of outgrowth in the colon that isn't cancerous, okay? But it can slowly become cancerous or malignant. That's another term we sort of use over a period of years. And it develops because of genetic mutations that accumulate within the cells within the bowel, driving this uncontrollable growth of the cells, okay? And it can progress from a polyp to invasive cancer, typically taking over 10 to 15 years. So that's important because that's a valuable window for early intervention, okay? So the things that are important here that you need to think about are key symptoms. So that's a change in bowel habit and a change that's normal to you, not normal to your friend or your family. Know your body, know yourself, and anything that's different for you, you go to your doctor and you say, this is different for me, okay? And that can be having more watery stools or having more hard stools, whatever is sort of different from your normal habit. Blood, really important. I get patients that come in and they're highly embarrassed to come and say that they've seen blood in their poop. There's nothing embarrassing about it. There's nothing embarrassing about changes in your bowel habit. Just go to your doctor if you notice something that's different for you. Unexplained weight loss, really important. You may have some weight loss and you may think, oh, great, the weight is falling off of me. It's fantastic. But if there's no identifiable reason, you're not exercising, you're not eating less, then why are you losing weight? So again, really important. And then abdominal pain that just does not seem to go away. So that's another sort of important key symptom where you need to present to your doctor. It's the second most common cancer in the UK by deaths. 94% of cases occur in people 50 and over, but the success rate, the survival rate, if you're treated at stage 1, is very early, about 90%. So let's look at bowel cancer in Black communities. So the cancer incidence and mortality lower in Black people compared to white, which on the surface appears reassuring. However, there's a critical exception here. Early onset bowel cancer tells a very different story. Okay, very different, 5.5% in white compared to 15.5% in Blacks, okay? Now that's really important. So that goes back to knowing your body and knowing what changes you experience, because again, we're looking at early onset disease where we're not screeners yet. So that's why any changes, really important, go to your GP. But there's a screening gap where, as I said, screening begins at age 40. So for the majority of Black patients who may develop early onset bowel cancer, don't fall into this screening program. That's why it's important. Any changes, anything that's different for you, you go and you get checked, okay? But we can't talk about being diagnosed with bowel cancer without thinking about diagnostic delays, okay? For Black patients, they experience 10% longer waits to access cancer sites, okay? And this again compounds the disadvantage of a later average diagnostic age. So this is why advocacy is really important. Really important that if you feel you're not getting through, if you feel the system is failing you, if you're feeling that things aren't working for you, you need to sort of then think about the community around you and think about how they can help and advocate for you. And obviously there's always, complaint channels like PALS and the rest of it, okay? Cervical cancer. So 3,300 new cases in a year. The vast majority of cervical cancer cases is caused by the human papilloma virus, so the HPV virus, okay? The age range for screening, as my colleague will discuss later, is 25 to 64. So essentially it develops where cells in the lining of the cervix, so that's the end bit of the uterus, the bottom bit of the uterus, where it gets this persistent infection with high strains of the HPV virus, normally 16 and 18, they're different strands. And there's progression. It progresses from infection to then various different stages of cellular abnormalities, which can then progress into cancer. And again, like bowel cancer, this takes typically 10 to 15 years. So there's a long window for detection. Okay, but most importantly, not all HPV infections progress to cancer. So sometimes you may go and have your cervical smear, it may come back that you're positive for HPV. That doesn't necessarily mean that you're going to develop cancer, but it does mean that we need to look at you a little bit more closely, bring your screening times to shorter intervals, really important. Symptoms, unusual bleeding. So that's unusual bleeding in between your periods, after sex, or any postmenopausal bleeding women, really important. You need to go and see your doctor. And any unusual vaginal discharge, pelvic pain, and early disease is often asymptomatic as well. So again, that's why it's important to engage in screening, but any changes in your menstrual cycle, you need to just go and have a check, okay? You can't put it down to stress, which can be the case sometimes. You need to just go and get it checked by a health professional, okay? Risk factors, having the HPV vaccination, smoking, immunosuppression, and not attending regular screening. Just moving on to cervical cancer in our Black communities. The incidence is currently lower in Black women compared to white, which does provide some reassurance, but again, we can't just rely on this. This isn't the full story. Okay, there's still national gaps in data of the ethnicity of women attending cervical screening. Okay, and it doesn't usually publish the uptake broken down by ethnicity. So we actually don't know what this gap is. Okay, but what we do know is that lower uptake is continuously reported in qualitative data. So we know that there's a gap there, okay? We also know that the HPV vaccination uptake is lower in ethnic minority communities compared to white, and that has important implications because it then predicts initial widening in HPV-related cervical cancer incidence between groups. Okay, we also have to remember that this vaccination protects you from the HPV virus, which then can lead to cervical cancer. Okay, lung cancer. So this is where we have abnormal and uncontrolled growth. So cancer is any sort of uncontrolled growth of cells in a place where they shouldn't really be. Okay, there are two types. There's non-small cell lung cancer and there's small cell lung cancer. Risk factors, I'm sure you are all aware, 72% of cases, smoking is responsible. Passive smoking, also responsible as well. Any sort of aerosols that are carcinogenic, so cancer causing, pollution, and then of course a strong family history as well. So signs and symptoms: persistent cough, so a new or changing cough. If you're having a cough and it's ongoing for more than 6 weeks, you need to have that checked, okay? Coughing up blood, breathlessness, any sort of pain in your chest and in your shoulder, again, could be a sign or symptom of lung cancer. And again, we see here unexplained weight loss, okay? Fatigue, so feeling quite tired and drained all the time. And then recurrent respiratory infections, okay? So incidence, again, for lung cancer is lower in Black communities, but the tumor biology, so the type of cancer, diagnostic delays, and evidence gap are still concerns, okay? Fine. So there's a different tumor biology. So someone looked at, one of these studies looked at analysis of over 84,000 lung cancer cases and found that Black African and Black Caribbean individuals had higher rates of adenocarcinoma compared to squamous cell carcinoma, okay? in white individuals. But this subtype is commonly seen in non-smokers and in younger patients, okay? So that's about the tumor biology. So you may have this persistent cough. You may think, oh, it's nothing. I've had the flu. I'm still getting over it, which may well be the case. But if it's ongoing for quite some time, 4 to 6 weeks, you need to just go and get that checked, okay? And then, of course, the ugly face of diagnostic delays across Black communities rears its ugly head again. So we experience a 10% longer diagnostic intervals compared to white patients across cancer sites. And there's an evidence gap that we will see across most conditions where research is dominated by data from white populations. Okay, so then the causes of the adenocarcinoma shift in Black populations aren't necessarily completely understood. And then finally, abdominal aortic aneurysm. This is one that you guys may not be too familiar with. So we have this long blood vessel that goes from our heart, then helps to feed all of our blood vessels in our arms and in our legs. And that's called the aorta. And that runs straight down through the middle of the body. But sometimes with increased pressure, it can cause dilation, okay? And an aneurysm can develop where the wall is weakened and it's at risk of rupture. Risk factors: men, smoking, people over 65, cardiovascular disease, and chronic obstructive pulmonary disease as well. Again, here we have a lower prevalence in Black people compared to white, and this is observed across different countries. But these may be biological reasons in terms of the differences in the wall structure and connective tissues, okay? But the exact mechanism is unknown. And again, it's unknown because there's this critical evidence gap in how these conditions affect Black people. So that's why really it's important for us to participate in research to help answer some of these questions as well. So what I'll do, I'll just stop there and then hand over back to Dr. Linda Bello. Thank you.
Thank you, Dr. Veline, for that very lovely presentation. You really took us through everything, really, and there's already a few questions for you, but we will come to that after our next speaker has spoken. And it's my pleasure to introduce Ms. Pamela Njawe. She is the head of adult and cancer screening at NHS London, where she leads programs focused on early detection, prevention, and improving population health outcomes. She brings a wealth of experience. We're really lucky to have her in public health, and she's passionate about increasing awareness and uptake of screening services. Pam, over to you.
Thank you very much, Dr. Bello. Thank you, everyone. Thank you to the Khan Group for inviting me to present here today. It is an extreme pleasure to be able to present on something I work on day in, day out. So just bear with me, and I'm going to share my slides. And hopefully they are now in presentation mode. Can I have a thumbs up, Dr. Bello?
Thumbs up.
Okay, thank you. Right, so as she said, my name is Pam Njawe. I'm head of adult and cancer screening for NHS England, and I work in the London region. I'm also a nurse by background, and I'm going to give you a bit of an overview about the screening programs, most of which have been covered in terms of the actual diseases by Dr. Veline. So I think it's important to start by noting that health screening on the NHS for these population screening programs are free. Not something that you have to pay for, worry about paying for. If you register with a GP, you should be invited for these programs once you're eligible. Also important to note that screening does save lives. We've recently had the outcome from the COVID inquiry, and one of the key things that was pointed out was the fact that screening being paused during the period of COVID did actually cost lives, especially when it comes to something like bowel screening. So there were later diagnosis of bowel screening and potentially loss of life. So definitely programs that is important that we engage with. What I'm going to go through today, I'm going to talk about what screening is, talk a little bit about the programs that we've kind of had a background to already, a little bit of signposting, and then in the end, I do have a call to action for all of you attending today. And it might apply to you or people that you know. So encourage each other. So what is population screening? So I'll start with what it isn't really. So it's not when you go and see a health professional when you have a problem or you have a symptom. That is a completely different pathway. Generally with screening, as it's been mentioned before, you tend not to have symptoms of the condition, but you are in a group that's at higher risk of developing that. It tends to consider large groups of people who are at high risk of the condition rather than just small groups or individuals. So people who are invited at the time don't normally have the condition being invited for. So if it's known, for instance, that you've been diagnosed with breast cancer and you're going through treatment, you wouldn't then normally be invited for routine screening for a period. It's also important to note that none of these tests that are done as part of the screening program are 100% specific or 100% sensitive. And by that, I mean, it would not 100% tell you that you have the condition with a positive test, or vice versa. If you don't have the test, sometimes it will not tell you that you don't have the test. So those are called false positives and false negatives. When screening is approved by the UK National Screening Committee, there is the assurance that the tests are very, very high in terms of specificity and sensitivity before they are approved. I already mentioned that these are free on the NHS. But another really important principle within screening is about informed choice. So people need to know the benefits of screening, but also some of the risks or harms that can come with it in order to make a choice. And when you get invited, you get letters, you get lots of information with leaflets that tell you all of this. It's really important to read through them, have an understanding, and speak to anybody that you need to about them before you engage in screening. So I'm not going to go through this slide in detail because Dr. Veline has already covered what diabetic retinopathy is. I'll go straight into talking about the screening program for diabetes, for diabetic eye disease. So everyone who has diabetes from the age of 12 is routinely invited for screening. Generally, you're invited every year, but if you're found to have very, very low risk of retinopathy, you'll now be invited safely every 2 years. And that is actually based on lots of research that's been done over the years because it's quite a long-standing screening program. So the conditions that are screened for are retinopathy and maculopathy, both of which have been covered earlier on. And obviously, if anything is picked up at that stage, there is a referral into hospital ophthalmology services to get further assessment, potential diagnosis and treatment as well as required. So it's really important to engage with these services as you're invited. When I think of this, I remember seeing someone when I worked as a practice nurse years ago who was in his 30s, ethnic minority gentleman, and he presented with sight loss. He did not know that he had diabetes. It's really, really important that we engage with services when we have symptoms of any sort so that we have appropriate diagnosis to be able to be invited to screening programs as required. So I'm going to move on to abdominal aortic aneurysms, and Dr. Veline has already covered this in her slide, so I'm not going to go through it, except to say and to remember that this is one of the conditions that people can really have no symptoms at all. Although sometimes people might complain of persistent back pain or stomach aches, that could be an aneurysm, a sign of an aneurysm. In terms of the screening programs, so men are invited at the age of 65, because as we mentioned before, men over 65 are at greatest risk. However, if you're over the age of 65 and you've never been screened before and you're a man, you can actually self-refer into the program. And all the information is available on the NHS UK website. At the end of this presentation, there is a QR code that you can use to access that website. The test itself is a painless ultrasound, takes literally minutes, and the results are generally given on the same day. So some of the recent data we have, pardon me, shows that, excuse me, 8 out of 10 men who are invited actually attend, which is really good. It's good attendance. But what's happening with the 2 out of 10? Are they just making an informed choice not to attend, or they're not informed enough? Are you one of those 2 out of 10 who have not attended and who might now be considering attending? When I worked in the southeast of England, the provider there for AAA did a road show. So they attended an agricultural show, took the equipment with them, and asked men in passing about whether they need screened, how old they were, and whether they could be screened. On one occasion, they screened somebody who had an aneurysm that was 8 centimeters big. Now, Dr. Veline, in her presentation, one of the slides, it did show the different degrees of aneurysms. And if you have an aneurysm that's more than 5.5 centimeters, you're referred for assessment and potential treatment. This was a large aneurysm that was causing absolutely no symptoms, but was treated successfully, but could have, if not treated, been fatal. So bowel cancer, again, I'm not going to talk too much about this slide because Dr. Veline has covered this, and I'll go straight into talking about the screening program. So this program is open to men and women from the age of 50 to the age of 74, and it's based on a home test kit that's done every 2 years. People who've been diagnosed with Lynch syndrome are also seen as part of this program now in the UK, and they are seen with regular colonoscopy appointments as required. So blood found in the stool does not necessarily mean that there is cancer, but it does indicate the need for further investigations. So screening for bowel cancer can be preventative as well as early diagnosis and treatment, which is one of the most, I call it one of the most successful in terms of that in the UK. At the moment, about 6 out of 10 people who are invited attend. So we still could do better in terms of attendance in general. Right, same for breast cancer. Dr. Veline has covered most of this, but I just want to point out again that some cancers in the breast might be too small to feel. And that's really where screening comes in and has an important role. So breast cancer screening in the UK is offered to women aged 50 up to the age of 71. The program is for early detection of breast cancer. Breast cancer screening does not have a preventative aspect to it at all, but it's really important. The earlier cancer is diagnosed, the better the prognosis in terms of treatment. So the first invitation for people invited could come anytime between the age of 50 and 53 because it works on a 3-year cycle. So if you're 51 and you haven't been invited, chances are you'll be invited before you're 53. But again, if you go onto the NHS UK website and type in your nearest, put in your postcode, it will tell you your nearest screening centre, and you can actually call them and ask them. Generally, they're very happy to receive calls from the public and give advice. So the test itself is a mammogram. Understandably, some people are quite worried because it can be quite an uncomfortable test, but it's not very long lasting. It's quite quick. It doesn't take more than 5-10 minutes altogether. The screens are done every 3 years in the UK. And at this point, about 7 out of 10 women generally attend for their breast cancer screening when they're invited. Again, important that we close that gap and get as many women attending as possible. So moving on to cervical cancer, I think most of this background has already been covered. Again, it's most common in women who are aged 30 to 35, but obviously we screen from the age of 25. The screen at this point is a preventative program. So cervical cancer screening program is not actually aimed at finding cancers. It does find cancers, but that's not the aim of it. The aim is to prevent cancers. So as Dr. Veline mentioned, there is that really long time span between an HPV infection and development into cervical cancer. So there's lots of opportunity there to monitor and to treat early when needed, when cells start to change. I just wanted to mention something about the invitation process in the UK. So nationally, a lot of services are moving toward digital-first approaches to communication. So the cervical screening invitations now go predominantly through NHS app as a first instance. And don't worry if you don't have the app, because if you don't access that message, you will be sent a text message and eventually even a letter as required. Dr. Veline already mentioned the test is now for HPV, but if you're found to be HPV positive, there's a further test to see if it has started to have any effect on the actual cells in the cervix. Last year, the government announced plans to do home testing, so self-testing kits for people who are underscreened. And there are plans underway to roll that out at some point this year. We're told that about 5,000 lives are saved from cervical cancer screening each year. About 6 out of 10 women attend for screening, but unfortunately, that's a downward trend. And we know that it's a downward trend that we need to try and reverse. Hopefully, this talk today is part of that process. I'm going to talk a little bit about lung cancer and lung cancer screening. It's fairly new in terms of cancer screening program. Before that, it used to be called the Total Lung Health Check. So about 43,000 people are diagnosed with lung cancer in the UK every year. It's one of the most common and serious types of cancer in the UK. Again, generally no symptoms in the early stages. Screening is being rolled out. So you might wonder, if you are between 55 and 74 and ever smoked, why haven't you been invited? Because not all areas are yet fully rolled out for this program. I have put in a QR code where you can go in, look for your area and find out whether your area, based on your GP practice, has started this program yet. So I just wanted to touch on this because these are what I call the non-programs. These are not population screening programs in the UK at this point. Ovarian cancer has been quite topical over the years in the news. Why don't we screen for it? And despite reviews of evidence by the UK National Screening Committee, it has been found that there's not a test that picks it up at an early enough stage to make it a screening program. So it's currently not a population screening program in the UK. The other one that has been even more recent and more topical is around prostate cancer screening. There's currently no screening program for that in the UK, no established population screening program, but there is work going on to look at what we can offer, what can be offered nationally. At this point, men who are over 50 can request the PSA test from their GP, and younger men, I think from the age of about 45, who have a family history or of Black ethnicity can also request a test. So moving on to signposting, I have put a QR code. The one on the right is for the NHS UK website. There you can just type in whatever you want to search on, and it could be around screening or any other health condition within the NHS, and you get more information on that. Your general practice is definitely another place to get information. And also, there's a link here for the NHS app. So the QR code on the left is how you can download download information about the NHS app, but also how you can get it onto your phone or other device. So what would I like in terms of a call to action for everyone here? Take home messages. If you're not registered with the GP, please make sure that you register with the GP. The basis of population screening program databases comes from GP registration. And within that, also really important that you have your address updated, possibly your email even, your phone number. A lot of time we move and we have a long list of things that we do, but we don't always remember to change these details at a GP practice. These are really, really key bits of information. If you do have the NHS app, or when you get the NHS app, remember to enable the notification so that when information comes through, you get it as quickly as possible. I think most people are on WhatsApp now, probably all of us. So the NHS has a channel on WhatsApp as well, which is always worth following because you get really important health messages, both in terms of general awareness months and weeks and days, but also in terms of topical issues that might be going on. And please remember to speak up. If you have questions, if you have issues or concerns, speak to someone. Check on the website, who can you call? Speak to your friends, your family, your general practitioner, the nurse at your practice, any healthcare professional. Where can you get more information? Share your good experiences and discuss the ones that don't go very well with the relevant people so that things can be made better. But I definitely want to leave with a message. If you do have symptoms in between your screening episodes, please do not wait to be screened in a year or two, go and speak to someone, make an appointment, and try and get that seen to as quickly as possible. There are a few more links here. I'm not quite sure how this information is normally shared. I think it might go onto a website. And if that's the case, you can click on some of these links. But that's it for me. Thank you very much for the time.
Amazing. Thank you so much, Pam. That was, I mean, your last slide was music to my ears as a GP. I'm sure Dr. Veline was smiling as well. I mean, a lot of the information is available on the NHS website, but through us, your GPs, and we quite frequently send our patients messages. We're reminding about the smear test, reminding about lots of things, and sometimes the addresses are not up to date, or their numbers are out of date, and the NHS app, brilliant, everything's on there, you know. So really good, Shap, that you've said that. There's so many questions for both of you, and I think what we'll do first is I'll ask you some of those questions, the ones that have come from those listening, and then Dr. Veline will take about 3 or 4 questions, and then we can go to the next part of it, which is for you to briefly speak to us about meningitis, because I know a lot have joined in hoping to get even just some brief advice about what's going on. So for me, if I'm going to be cheeky, I'm just going to start first with you, Pam, because you mentioned something, and this is a personal question, because as a GP, and I'm sure Veline also has the same experience, that we see women that are reluctant to attend cervical screening because the barrier is the procedure itself, you know, like people are, you know, sometimes I have to give my patients things to calm them down because they're so scared of coming to the appointment. And I understand from your presentation that there have been developments around self-sampling for women who don't attend, which is really encouraging. Can you talk us through why this hasn't been more widely implemented? Is it mainly around cost or ensuring that test is accurate? Could you please let us know? Thank you.
Thank you. And that's a really good question, because I think as a woman as well, we've all been in that situation where you're facing the discomfort of a cervical screen. When the pilot and the studies were done into self-sampling with the kids, the population that was targeted was those who had never been screened or who were under-screened. And it was shown that there was better uptake in those women than there would have been before in terms of them attending at what I call conventional clinician-taken samples. So it's been rolled out to those women. But what we also know is that although it's a very good test, it is not as good as a clinician-taken test. So at this point in time, rather than not have anything at all, we're covering those women to some extent by giving them the option of the self-test. I suspect, my expectation, as the test is developed and improved over time, the European NSC will then be reconsidering whether it can then be a primary offer to everybody. And to be honest, I can't wait for that day personally as well, because I think most people would prefer to do a self-test. But at this point, if I am given the option of a slightly better clinician-taken test, I think I would go for that and feel more reassured for now.
Thank you so much for that answer. Dr. Veline, did you want to add something briefly? I saw you nodding your head vigorously.
No, just agreeing with Pam, just to say as many options as we have to make available to people who may not want to attend, even though it is the better option, should be more widely available.
Thank you. Agreed. So we've got a question from the chat. And I'll this one for you, Dr. Veline. What's the difference between a health check and screening? And I've heard that some screenings can give false results. How reliable are they, and what happens if the result comes back unclear?
Really good question. So by health check, I think people may be referring to the NHS health check that we start from age 50 and it's done, start from age 40, sorry, and it's done every 5 years. So essentially that's a health check looking at cardiovascular risk. So that's a test, that's a check where we're looking for any cardiometabolic conditions, such as any problems with your heart, like high blood pressure, for example. So that's really important. And you have some blood tests also to check your kidneys, check your blood sugars, and so on. So that's really important to identify any early cardiovascular diseases. So that's not a screening as such, but it's more a sort of check to see if you have these conditions, and we can start to treat them a little bit earlier. What was the other question?
The other question
Oh, false
was,
positive. Yes. So I don't have all the stats with me, but yes, with any sort of screening test, we think about how specific and how sensitive it is. And then we also have issues where we can develop false positives, but also false negatives as well. And where your result comes back unclear, you may be then called back to have the test redone, or called back to have a different or additional investigation. So it's not just sort of left unfounded. It's always that you're contacted and encouraged to do further test or an additional examination.
excellent. Thank you for that. The next question, I think any of you can answer this. Is it always the case that cervical cancer stems from HPV?
So we never use the term always in medicine and never. That, if you ever see that on a multiple choice as a medical student,
Yes.
it's false. No, but 99% of cases do tend to stem from HPV, the HPV virus, essentially. So we know that it's highly associated with that particular infection.
Yes. So, I mean, we do get a lot of smear results saying HPV positive, and a lot of my patients will call and they're so worried. Where did they get it from? Could you just explain a bit more about HPV for people? Because this is one of the things where people think perhaps somebody has, they've given it to them. It's the partner has been unfaithful or something like that. And also about the fact that the body can also just get rid of it itself, and that's why we monitor them. So do you mind just saying a bit more about it?
I think you've explained it quite well, Dr. Bella. I think you can go on, because I think you've explained it eloquently. You do see a lot of women getting really upset and really sort of worried about this, about it. It's come back positive. What does it mean? Like being really, really fearful. But our bodies are designed in a way to clear that infection very, very quickly and very, very readily. And not all HPV positives then lead to cell changes and lead to cancer. Really important. So that's why if you test positive, someone may say, well, they're not going in and doing anything. They're just waiting and then having another test. But we're having another test because your body can clear it, essentially. So that's why you're brought back for more testing. And our bodies are designed in a way to help fight that infection that's fairly common as well.
And a little segue into the HPV vaccines. I mean, a few people, a lot of older patients, because obviously the HPV vaccine is not being offered to adults, want to come frequently asking me, should I go and get it privately? What would both your advice be about that? I think you can only get it up to 40. What would your advice be about that?
Ooh, I'll hand that one to Pam.
Yeah, I was going to say I think it's a difficult one without making some further references, because I think it's up to 25 maybe in the program, and then there are exceptional cases where it goes up to 40. I think it's a very personal choice.
Mhm.
But bearing in mind everything we've said about how long an infection like that would take to kick in and have an impact on the body, I mean, it has to be a personal choice, because the NHS doesn't recommend it for a reason. It's not that we just don't want people just don't want to be given it. I think if people think they would feel happier, safer to go private and do this, I would be reluctant to tell them otherwise. But at the same time, if they just feel they'll just have regular screening that will pick up any infection, and it will be monitored appropriately, that is also a very reliable way to go.
Thank you so much. And as we were speaking, a question just came in through the chat, which was saying, can we explain the role of, if any, of sexual relationships in HPV infection, which we've just spoken about?
Yeah, sorry.
Oh, sorry, go ahead, Pam.
No,
Sorry.
no, I was going to say that's another really tricky one, because we get told that the main transmission is that, but we don't know how long, what else, how else it could have been transmitted. I think there's still a lot of unknowns. And when we personalize it and try and it and affect our own private lives and our relationships, it could detract to a large extent to exactly what we're trying to achieve. So I tend to reassure people and say, look, let's focus on what it is, whether your body's going to clear it, and take it from there. In terms of partners and what happened or not happened, again, I would find that very, very tricky ground to go into.
But is it sort of safe to assume that if you didn't have any sexual relationships, then you wouldn't be at risk of HPV, right? Which is why sometimes we do, some of our patients who don't want to have a smear, if they're not sexually active, we allow them not to. Dr. Veline?
Yeah, similarly,
Yeah.
and also if you are at high risk, where for example, if you are a sex worker, if you do have lots of high sexual partners, then you are at high risk, and we do invite you to have that, ensure you're having that smeared.
Perfect. Thank you. More questions. We'll probably have time for about two more, and then we can go straight to your presentation. What misconceptions link organ donation fears to screening attendance, and how do you address them?
I would need to look what the misconceptions are. Do you know? What exactly is a misconception?
That's how the question has come in, and I'm wondering whether it's to do with the fact that there's been always a bit of issues with, in the fact with sort of inappropriate research done on Black people
Yeah,
and all the hesitancy,
yeah.
and whether or not, but I don't actually see how the two are related in terms of screening, because obviously it's more us that need to be screened because we don't attend these things. So I'm not sure. Could the person who wrote the question, if they can just write another one so that we can understand more and we can explain that to you, that would be really helpful. Excellent. And last but not least, another question from me. It's my personal bugbear. PSA versus CA125. So PSA, we sometimes offer it when people come with symptoms, but CA125, no, we're not really using it. Pam, any thoughts about, because you mentioned about the fact that PSA might be a test that might be used perhaps in conjunction with other things. What about CA125? What's the thoughts on that?
Yeah, I don't know if there's been any recent evidence submitted about how early CA125 can detect ovarian cancer. The last review that was done, I think it was based on a study, maybe 2017 or so, and it did show that there was really no change in terms of lives lost to ovarian cancer by doing a CA125, and is at what stage of study, etc. So I think there will be much more technical detail that I would not even begin to try to understand with this. But I also don't know if it's a fair comparison in terms of two different tests for different conditions, and whether we can actually say, well, if they're going to be looking at PSA for prostate, why are they not looking at this? I think the UKNSC looks at all evidence that is provided, it's that is submitted to them. But also just to say, just generally, as it's been mentioned about Black people in research, it's really important that we engage in research when we can, so that there's a basis of evidence that is very specific to our population that can then be used when some of these decisions and recommendations are made on a national level. But I see.
That's that's music to Dr. Valine's ears, I think.
And also, I think it's important that we as doctors, when patients come in, we see the individual. I think one of the issues that has been raised with CA125 is that it can be elevated in lots of different conditions and falsely elevated, and not necessarily a sign of ovarian cancer, but a sign of other things. So, for example, fibroids, as an example. So, but just because of that, that doesn't mean we shouldn't use it. We should still use it in the context of the patient in front of us, and we should be able to offer all investigations that will help us to guide all clinical diagnosis. Even if it isn't sort of what's nationally recommended, we still should use everything we have in our arsenal to try and find a cause for particular symptoms that people may be having.
Thank you. We've got 2 questions that have just come in. I think I've been encouraged to ask these. And that's basically linked to what we've just been talking about. How can participation in regular health screening help build trust and correct these organ donation myths in the Black community? And then there's one about HPV, which I'll come back to. So how can participation in regular health screening help build trust and correct organ donation myths in the Black community?
Yeah, I think it's really important. I think if you have from my earlier lectures or earlier slides, essentially what I did show is that there's this evidence gap. Okay, there's this evidence gap in how we experience these different types of cancers. Yeah, and we don't have enough data of our ethnicity in these large databases. So by participating in research, we get to understand these or answer these questions more readily, but we also get to share within our various communities and our families the benefits of screening, the benefits of being checked early, the benefits of preventing cancer, and the benefits of experiencing treatment. And of course, there's largely widespread mistrust of the medical system and of research in general. However, we need to say at this point, it's really important for us to participate, really important for us to have our data included so we can answer those questions for us, our family, but also for future generations as well. And then spread the word that it's also important as well.
Exactly. And I think also we've had a few research webinars. We had one in Camden, Can also had one to see that actually there's people like you that are working in these research teams, so, I think that's also very helpful. Lots and lots and lots of questions. I'm bearing in mind that we do have one other presentation that we want to do. We are going to run over, but can one of you just discuss about the HPV vaccine? Because there's a question about the fact that it's being offered to boys aged 12 to 13 currently. That's what they've written in the thing. Can you just explain more about how that works, why that's happening? Because I think it's quite a topical thing at the moment in the chat.
I don't know if Dr. Veline, you know more about the HPV vaccine. I would say I'm not very au fait with the age group at this point in time, but it's offered to boys and girls in that age range. The reason for offering it early is that it just starts that immune process going, so that by the time that they're adults, by the time that they are engaged in sexual activity, they are actually protected from the HPV virus, from HPV. So that's the reason. The earlier it's offered, I believe, the better, because it allows the body to build the immunity that it needs over the life course.
So HPV is offered to, I guess, 4 main groups. Children 12 to 13, so that's boys and girls, to my knowledge. It should be offered to both genders. And young people up to age 24 who missed getting the vaccination as a child. So that's another group. If you missed that vaccination when you were a child, then you're still eligible up to age 24, as Pam said, because you want to get the immune system sort of going earlier. Okay, and then we also have men, and maybe this is where the confusion came. There's men up to age 45 who have sex with men. So maybe that's where the boys and the men thing got a bit confused. And then finally, the last group are people who are at high risk of HPV. So that includes men that have sex with men, sex workers, people with HIV or other immunosuppression conditions as well. Yeah. So those are the 4 main groups that are eligible for cervical screening.
Wonderful, wonderful. So I think we'll end there for this slot. Before we go to the next presentation from you, Dr. Veline, if there's one key message that you want everyone to take away about screening, what would it be? So over to you first, Pam, and then Dr. Veline.
So one, it can indeed save lives. It is worthwhile getting engaged in, and do as much as you can to make sure that you're in a position to accept the invitation when it comes.
Okay.
Yeah, similar to Pam, I think people get sometimes a little bit anxious or nervous when that letter or text message comes in, because they say, I feel good, I don't want to know what's not known. And I think don't let that fear or that anxiety stop you from being treated early for cancer that could be picked up via screening. And if you are worried and are anxious, I think it's really important to book in with a healthcare professional and discuss those fears rather than just ignoring the letter.
Perfect. That's wonderful. Now, I'm aware that we are at 12:04, but I think I've been given the permission to ask Dr. Veline to continue with another presentation, which we thought was quite timely, given the meningitis outbreak that we had in Kent. So over to you, Dr. Veline, to give us a brief presentation. And thank you for doing this at such short notice.
Not a problem. I know there's a lot of anxiety and fear about what's going on with the meningitis outbreak in Kent. So far, there have been 29 either confirmed or under investigated cases, and sadly, two deaths. It has been linked to a particular nightclub between the 5th and 7th of March. So then we have university students and local schools being affected. But really the focus is around those age 18 to 21, because as university students, they live in confined spaces, they have interactions within groups, okay? And this is really about the meningococcal B. There's lots of different other strains of meningitis as well. So what is important to know? It's important to know the key symptoms: sudden fever, headache, vomiting, not being able to tolerate bright lights, confusion, drowsiness, stiff neck, cold feet or hands, severe limb and muscle pain, and a rash that doesn't fade. And I'll come back to the rash in a second. So, and again, a lot of these symptoms are sort of non-specific, okay? And a lot of us experience these with other ailments as well. So I think the key here is that in this current climate, if you experience any of those, then you need to seek help urgently, okay? If friend, again, contact 999, go to A&E if you're feeling that these symptoms are affecting you. If you're unwell but you're unsure, then there's always 111 or speak to your GP. Don't ignore any worsening symptoms, because early treatment does save lives. So if we go to the next slide, the rash. So really important, when we think about the rash, it may not have that pink reddish color in darker skin. Instead, it may be bluish, black in color, almost similar to what your skin looks like when you have a bruise, okay? So that means that the spots or the rash may be easier to see on the palms of the hands and the soles of the feet or inside the mouth. But this is the key point to take away here. Do not wait for a rash, okay? Do not wait for a rash. If you have the symptoms I described on the previous screen, seek medical attention, particularly if these symptoms are progressing quite rapidly. So do not wait for a rash. I think that's the key takeaway here. And if there is a rash, you need to just go straight to A&E. Call 999 or go to A&E. Really important points. So what does the rash look like on darker skin? So here are a few pictures. As I said before, you can get that sort of bluey, blacky color. You can also get sort of a darker purplish color as well. And I'll just show a few more. So again, these are just various different variations of what this can look like. Really important. So if you're concerned about meningitis, as we all are, you need to go to a trusted resource. And that is on the government's website. There's meningitis patient fact sheet that you can go to that gives you an overview of what meningitis is, what bacterial septicemia is, what viral meningitis is, because there's a difference, and about vaccines that can protect you as well. And again, Pam put up a QR code earlier in her slide that you can click on for the NHS UK website, which again gives you additional information. And this is just a short sort of overview in terms of the vaccine as well, which people are eligible for if they have been exposed to this outbreak, or if they have symptoms as well. So it's a bit too that the government is now doing. With everything, there's of course side effects that you get with any sort of vaccination, but really important that this vaccination, people who have had the vaccination, it protects against most, but not all, strains of meningitis. So again, even vaccinated people still need to know the signs and symptoms and seek urgent help if there's any concerns. And then finally, this is a plug from me about research. I co-lead a large cohort study called Black Health Legacy. It focuses specifically on diseases that affect people from Black backgrounds. So again, if you're interested or want to know more, you just put in Google Black Health Legacy, and you can find out a bit more information as well. So I'll just stop sharing my screen, if I can do that. Let's see. Oh yeah, I can stop. Oh.
Amazing. Thank you so much. I'm just gonna, that was so good, just being able to see the pictures of the rash, because of course rashes always look a bit different in our skin tone. So it's really good to highlight that. And as Dr. Veline said, all the information is on the NHS website as well, gov.uk. Now, Apology has just asked a question whether an adult can get a vaccination for meningitis.
Not through the NHS vaccination programs. However, if you have been exposed or if you have symptoms, you will be offered the vaccination at this point in time.
Excellent, excellent. I think one of the things that some of the calls that we got this week was people scrambling to find out whether their children had the vaccination to the meningitis strain that was currently in circulation. Could you give people some advice on what you feel they should be doing if they're not sure? I mean, obviously it's in Kent, but people are, I practice in Colchester, but we still had some of these calls last week.
Yeah, I think the most important thing to do is, if you have the NHS app for your child, you can have a look and see what vaccinations they have or haven't had. And equally, you can also call up your GP or send them a message and ask whether they've been vaccinated or not, if you're unsure.
Amazing. And I can see another question just came in through the chat. I've had the vaccination for meningitis C in 2012. Is it applicable for the B too?
On the face of what you're asking me, the answer is no. But again, you need to go back and get that checked, because maybe they mentioned C, but you could have been protected against other strains as well. So that's why it's important to go back and see what's in your health records.
Odette's just saying, thank you so much for the explanation and showing how the rash looks on a black skin, because we are always told how it looks on white skin. So they're very appreciative of that. Well, Thank you so much, Dr. Veline, for that whistle-stop tour on meningitis. It was really helpful, as you can see. And I think it's a good time now to bring the session to a close. We're only 12 minutes late. I'm so impressed. And we've covered so much today. So I want to thank you both, Pam, Veline, for such an insightful session. To everyone who has joined us today. We really hope that you feel more informed, empowered, and confident to take charge of your health. Please do share this information with your family and community because early detection truly saves lives. Thank you and have a wonderful day, wonderful rest of the weekend as well. Cheers.
Thank you.
Thank you.
Hi everyone. So thank you for attending the Health Hour today. Thank you, Dr. Veline, Dr. Palm, and Dr. Bello. So just before we close, I'm just going to go over a few updates before our next Health Hour session, if that's okay. So for next week, we will be tackling prostate cancer. I hope everyone can see my screen. Yeah?
Yes, we can see.
All right, that's great. So next week we'll be tackling prostate cancer. So it's the same time from 11 a.m. to 12 p.m. If you want to register, please email info@can.org.uk. We also have our Black Healthcare Awards nominations. Black Healthcare Awards. The nominations are still open. So if you know anyone, any professional making a difference, a real difference in the Black healthcare space, join us in celebrating excellence and innovation. Contact the Black Healthcare Awards at can.org.uk for more information and to nominate somebody. We also have an upcoming webinar called the Family and Advocacy Webinar. So this time we're going to be talking about adult social care. So rights, eligibility, and support. So this is the webinar that I'm personally leading on. So allow me to be a bit biased over here. So with this webinar, we're talking about adult social care, essentially, bridging the gap between adult social care services and people in the Black and ethnic minority community. We realize that people do not usually reach out for care when maybe they've suffered an illness, a disability, or they need more support. And there's a bit of a myth about what kind of support they can get from adult social care. So we're trying to, eliminate those myths and also encourage people to reach out for the appropriate support. So if you're interested, please contact advocacy@can.org.uk. I'll also put the registration link in the chat, and I hope to see you all next week, Wednesday. We also, sorry about that. Yeah, so, sorry, my screen is messing up a bit. Yeah, so we're also having the Black Health Inequality Summit. So it's happening on the 20th of April from 9 a.m. to 4 p.m. at the Mermaid. So that's in London. So if you want more information about that, please contact events@can.org.uk. And we also have our Black Health Legacy. So this is help make health research more inclusive. So we'd love to hear your experiences, views, and ideas to help shape more inclusive research, improve representation, and influence how studies connect with Black audiences. So this is going to be an online survey. And if you're interested in it, please send an email to research@can.org.uk for more information. And yeah, we also have our digital inclusion research. So we're looking for people in the Black community to share thoughts and stories and ideas on how research reaches and represents you. So if you're interested in taking part of it, kindly scan the QR code on the screen and register your interest. So thank you all for joining us today, and we hope to see you all next week. Have a lovely weekend. Bye.
Bye.
And that's our time for today. Whether you joined us on Zoom, Facebook, LinkedIn, or YouTube, thank you for making the Health Hour part of your Saturday. We hope today's session gave you the right dose of health wisdom that you can share with your friends and family. When we share knowledge, we strengthen our entire community. Mark your calendar. Next Saturday, same time. Got a topic in mind? We want to hear from you at health@can.org.uk. Health Hour, hosted by the Caribbean and African Health Network.